Good afternoon. My name is Robin Jones. I'm the Stroke Program Manager for Mission Health, and I'm here today at Rutherford Regional to talk to you about telestroke, and we're going to cover several items. This section now we're going to talk about is the reconstitution of alteplase, the drug that has been approved by the FDA for acute ischemic stroke. You do stock this in your emergency department. It is used in acute stroke, and we want to go through the steps so that you feel very confident on that shift when you have to actually treat a patient. One of the first steps before reconstitution is that I'm going to implore upon you to have the drug at the bedside. So when you activate a code stroke, telestroke, and you're working through that assessment with the teleneurologist, I want you to have the drug in the room ready to mix when the physician determines he or she would like to treat. So first, before mixing the drug, you do want to verify with the neurologist and the ED provider the plan to administer IV alteplase. You want to have the alteplase at the bedside and be prepared to mix it and give it as soon as ordered. Ensure all the contents of the box are present. In the box you will have one vial of the diluent and one vial with the powder. During the mixing you want to use aseptic techniques at all times, including thorough hand washing and the use of gloves. Noticed on the slide that you have the sterile water for injection and the alteplase powder, and in the box is also a transfer device. When you're ready to mix the two, you remove the protective cap from the top of the alteplase vial and the vial of the sterile water. Swab the top of each vial with an alcohol wipe to reduce the risk of contamination. Remove the transfer device from the wrapper and remove the plastic protective cap from the other end. Insert the piercing pin vertically into the center of the stopper of the vial of the sterile water, keeping the vial upright. Remove the protective cap from the other end of the transfer device and, holding the vial of alteplase upside down, position it so that the center of the stopper is directly over the exposed pin of the transfer device. Push the vial of alteplase down onto the transfer device, making sure that the piercing pin is inserted through the center of the alteplase vial stopper. Invert the two vials so that the vial of alteplase is on the bottom, right side up, and the vial of sterile water is on top. Allow the entire contents of the vial of sterile water to flow down through the transfer device into the vial containing Activase, a process that requires approximately 2 minutes. About a half a milliliter of sterile water may remain in the upper vial. Do not use bacteriostatic water for injection. You will only use the sterile water that comes in the box with the powder. Remove the transfer device and the empty sterile water container vial from the alteplase vial and safely discard both the transfer device and the empty diluent vial into a Sharps container. Mix the solution with a gentle swirl or slow inversion. Do not shake, and I cannot emphasize this enough. If you shake, you will create foam, and the foam you will not be able to withdraw from the vial. So you want to take the time to let this dissolve. Slight foaming of the solution is normal, but you don't want a full vial of foam. Let the solution stand undisturbed for a couple of minutes to allow any large bubbles to dissipate. Visually inspect the alteplase solution for particle matter and discoloration before administration. If alteplase is mixed and not administered, notify the pharmacy or stroke coordinator for reimbursement. The company will reimburse the hospital and exchange the vials if during the situation it's determined that you are not going to use it after you have mixed it. You don't want to save it for another patient, so you want to return it to the pharmacy complete, intact. You want to go ahead and, if we're going to treat, you're going to prime the IV tubing. Use a syringe to remove waste dose from the tubing port, or remove your waste dose directly from the vial, whichever is your hospital policy. Remove the bolus dose from the tubing port and administer the bolus dose. Administer the infusion. When alteplase is empty, hang a 50 milliliter bag of normal saline at the same rate until the volume to be administered on the pump is infused. Once you start the TPA, you begin your monitoring protocol. And initiated with the bolus, you will want to do neurochecks and vital signs every 15 minutes times 2 hours, then every 30 minutes times 6, and every 1 times 16. If you are transferring the patient from Rutherford to another facility, you want to make sure that the transporting personnel know exactly how much is left in the bottle, how much is yet to be infused, and where you are in the monitoring of your patient. Remember that no neurochecks or vital signs should be missed at handoff. The blood pressure goal is less than 180/105, and you want to stop the alteplase TPA and notify the provider stat with any signs of neurologic decline, major bleeding, and or mouth or tongue swelling. Again, you want to, for some additional post-IV alteplase monitoring, you want to assess the IV site frequently during administration and notify the provider if any signs of infiltration. If you do note that it's infiltrated, you need to stop the infusion, but do not discard the dose. The provider may elect to continue the infusion via an alternate IV site. Close observation and frequent monitoring of patients for neurologic changes, any signs or symptoms of intracranial hemorrhage, and any signs of adverse drug reactions are important in patient recovery. Stop the infusion if any signs of acute neurologic change and notify the provider, and prepare for repeat CT scanning. Intracranial hemorrhage is the principal risk factor of IV TPA in ischemic stroke. In the initial NINS trial, they showed that 6% of patients receiving IV alteplase for stroke had an intracranial hemorrhage. That's 6 out of 100. Typical rates now are around 2 to 3%, but it still can happen, and you want to be prepared for that. That's the rationale for the frequency of neurosigns and vital checks. It usually occurs within the first 4 hours of TPA administration, but it can be fatal. Angioedema or tongue oral swelling is also, it's a less common side effect or risk factor, but it can be just as potentially high risk. The literature supports that it occurs in about 1 to 5% of all patients who receive IV alteplase for stroke, and it can be as demonstrative as the picture I have on the screen, or it can be as minor as unilateral lip or tongue swelling. So in addition to your blood pressure monitoring, and you want to keep the blood pressure less than 180/105, American Stroke Association guidelines recommend the use of labetalol and or nicardipine to maintain this blood pressure range. Again, with neurologic status, you want to notify the provider and the neurologist and be prepared to do a stat CT scan of the head without contrast to rule out a post-TPA hemorrhage. With oral checks, I would recommend that you add this to your vital signs and neurochecks, and so that you're doing it at the same frequency. And you want to check for swelling of tongue, lips, or oral pharynx. We have seen that in the literature it reports that those patients who are also on an angiotensin converting enzyme or ACE inhibitor use and with infarctions that involve the insular and frontal cortex. Empiric treatment with antiphylactic medications, Benadryl, methylprednisolone, and others actually are the way you treat this patient. Before we show a demonstration of this, I do want to mention that with interfacility transport of patients post-TPA, there is a new relatively new statewide protocol for paramedics to follow, and this is for transporting the patients post-alteplase or during administration of alteplase. This protocol mirrors what the standard that is set within the hospital for the frequency of vital signs and neurochecks and angioedema. This protocol also includes what the paramedics should do in case there is blood pressure to be controlled or signs of allergic reaction or intracranial hemorrhage. And I think at this point I'll stop and for any questions, and we'll do a demonstration of how to mix the alteplase. Good afternoon, it's Robin Jones, Stroke Program Manager for Mission Health, and I have with me Kelly Pace, an RN from the Emergency Department at Mission, and we're going to walk through the actual reconstitution of alteplase IV for IV use. And you have this stored in your emergency department. It is in the Pyxis. Again, we want you to have this at the bedside if you're working a code stroke so that you're able to mix this as soon as possible, remembering our door to needle times. We're we're going to go through the reconstitution of the 100 milligram vial. That is what most emergency departments now stock. A reminder is that for acute ischemic stroke, we only give 90 milligrams, but it comes in a 100 milligram vial. And so I just want to make sure that everybody's clear on that. And so to start with, you get the box out and have it opened up, and in the box you will find that you have one vial with powder and one vial with a diluent, and this is sterile water solution for you to mix together here. So you want to use aseptic technique when you're mixing these two together, so I would be wearing gloves, but I don't have any. Also in the box you have a transfer device, and so you want to make sure when you open the box that you have all three things in here. You may also want to keep in either a clot box available on the unit, or in the Pyxis, a dosing card and the supplies that you'll need to draw up your waste and your bolus and to hang your drip. And so we'll go through that clot box as well. Once you are ready to prepare this, you will take and your diluent, you will pop the top off, and your powder, and you have a transfer device, and again using aseptic technique you will swab each one of these vials to make sure that they're good and clean before you actually puncture them. And with the transfer device you will open this up, and the transfer device has two sides to it, and you will take the top off of one and you will puncture the fluid or the sterile water, and then remove the cap from that and take your powder and put it over the top of the device and puncture that. And then you want to invert the bottles. So you invert so that your diluent will actually now be filling up to where you have the powder. And you may have a little bit of extra fluid in the diluent vial. If you pull back a little bit on the transfer device, you can drain all of the fluid into here. You want to be careful not to shake this as it is doing, but once it's completed, you will remove the fluid from here, and you now have your fluid in with your powder. You very gently swirl this. You don't want to shake. If you shake, you'll end up with a lot of foam. You also want to be able to look in here and look at the fluid and see that it's clear. It may be slightly yellow, but you want no particles in there. It may take 3 to 4 minutes, and during this period of time you can put this to the side, let it be dissolving completely while you're calculating exactly your dose and priming your getting all your supplies out to use for that. And so Kelly's going to give us an example weight now and how she will mix and give the bolus and the drip.
So we have a code stroke box. Your facility may want to look into getting one, but we just have a bunch of supplies in here, like the 30 ml syringe, we've got 10 ml syringe, we've got needles, IV tubing, and the 50 ml bag of saline that we hang after the TPA, some alcohol swabs and some labels, and also some extra information and guidelines in here. But we also have our dosing chart, which is a reference here to figure out exactly how much we need to waste, how much we need to administer as a bolus and administer as an infusion. So what we'll do here as an example is we're going to pretend that our patient weighs 80 kilograms. So I will go and find the 80 kilogram section right here. And once I slide it on there, it will give me my total dose, my bolus dose, infusion dose, and the unused quantity. So here it says for an 80 kilogram patient that my total dose will be 72 milligrams, which is 72 mLs. So what I first want to do is I want to go ahead and waste the unused quantity, which it tells me right here, 28 milligrams, which is 28 mLs. So we'll take the infusion here, and we'll go ahead, this will be 100 mLs or 100 milligrams once we've mixed it. So we want to go ahead and get my 30 ml syringe out here and draw out 28 mLs of the solution, and we'll go ahead and waste that. So this will be now, this should be 72 mLs, which is my total dose. And then it tells me right here that my bolus dose is it's going to be 10% of that, so 7.2 milligrams, which is 7.2 mLs. And I'll pull that out in a syringe, which I have a 10 cc syringe here. I'll pull that out, and I'll go ahead and administer that over a minute. And then with the remaining dose, which should be 64.8 milliliters or milligrams, we'll go ahead and spike that, and we'll hang that over an hour. And what I tell everybody is just to set your pumps when you're going to set it to over an hour, that you set the volume just a little less. Depends on what kind of IV tubing you're using, just so that you don't infuse the whole thing and then you get bubbles in the line, because after that you're going to hang your 50 mLs of saline, and so you don't want a whole line of air and then start this. So try to program it just a little less than.
And the rationale behind that is really that because if you have your pump tubing and your TPA goes down to the cassette on the pump, and it now says infusion complete, you still have drug in the tubing from the pump to the patient. And so we hang the saline to continue priming the tubing, and so that the patient gets the entire dose. A couple of other things I'd like to point out here, because you may be doing what we call drip and ship, which means that you're going to start the IV TPA drip and then you're going to ship the patient to Mission Hospital. If the transport team does not use your pump, you need to make sure that you transfer all of the drug to their tubing that they're going to use on their pump. Or if they're going to take your pump, you want to make sure that they take the saline with them. So if the transport team is taking the patient while the TPA is still infusing, you want to make sure they get the saline so that they can complete the infusion, because Alteplase is weight-based, and a stroke patient who doesn't get their complete dose is not getting the complete treatment. And so I want to make sure that we all are clear on that. Lastly, when you're hanging this, Kelly mentioned that our patient would get 72 milligrams, but a portion of that was the bolus, and so you want to put on the label what you hung here was a total of 72 milligrams, bolus 7.2 milligrams given, and then the drip is the remaining of that. So again, that whoever you're handing this patient off to, whether it's a paramedic with ground transport or a flight nurse with mama, or to your own intensive care unit, that nurse knows exactly what has been given and what needs to be given. Again, with IV Alteplase, you need frequent monitoring, and that begins with the bolus dose. And so you want vital signs, neuro checks, and oral checks every 15 minutes for 2 hours, and then every 30 minutes for 6 hours. And then if you still have the patient, it would be every hour for the remaining up to 24 hours of monitoring. It's extremely important to do a good handoff. So if you're transporting this patient and you're transferring the care over to a flight nurse or to a paramedic, you want to do a quick neuro assessment on the patient, and so that person now taking care of that patient, picking up responsibility, will know what does the baseline stroke symptoms look like, because one of the side effects of an Alteplase may be a decline in neurologic status if they happen to hemorrhage. And so it's very important to do that handoff communication. And thank you very much, Kelly, for showing how to do this. Thank you.